Apparently there's an echo when I talk. I don't know why that is. Right, I think we're now at 2 minutes past 10, and we seem to have got a pretty good number of participants, well over 120. So thank you all for joining us. We're here with some great speakers to talk about the very important issue of how we as a system tackle the backlog of urgent needs post-COVID. I guess as context, we're all aware that over probably the last 15 years, the NHS has made huge strides in various ways to create quite a dramatic drop in waiting lists in most areas. Unfortunately, COVID, obviously, that's gone back up. I guess this raises a number of interesting questions that we're going to try and address or answer in this event. I mean, firstly, I guess what will be the true number? I think the official waiting list is 4-point-something million last time I looked, but I've heard estimates from Nuffield Trust and other places that there could be another 6 million who haven't even got onto the clock, as they say, because they haven't yet got to see their GP or got an appointment. So I guess, you know, what is the true number? People talk a lot about elective surgery. Clearly, there's a whole lot of other services, and particularly mental health, the consequences there and the waits for accessing mental health services. Another big issue, I guess, some of the treatments, it's not just the delay, it's what are the consequences of delay. And obviously we've got Gordon to talk about cancer and the consequences of diagnosing cancer at a later stage than we otherwise might have done. So a lot of issues around what is the actual demand that's been caused by COVID. I guess then there's a whole set of issues around how will the sector cope to get that waiting list backlog down. I mean, so one issue is that if before COVID the waiting list was growing, the run rate of capacity was below the run rate of demand. So to actually create the capacity to now reduce that backlog, that seems like a pretty major challenge. I think in terms of the capacity, there are a number of issues, I guess, sort of infrastructure issues around what impact does COVID have on capacity, if there's got to be extra procedures to manage infection control and things between procedures, that reduces capacity. Probably the big issue is staffing. We're already short of staff in a lot of areas. A lot of staff are probably pretty burnt out after a year or so of COVID. Probably don't want to do a lot of extra shifts and extra work. Probably quite a lot of staff thinking about early retirement if their NHS pension pot is full. So quite a lot of issues around how we create the capacity. I guess there's an issue, we've got a couple of private sector speakers, elected speakers, about what will be the role of the private sector. Will they go for the inevitable growth in self-pay and private work, or will they focus on helping the NHS out? And I guess probably there's issues we should think about in terms of lessons for the future. You know, what should we do to put ourselves in a position to cope with any future pandemic in a better way in terms of workforce planning, what implications does it have for infrastructures and buildings, you know, what about technology and telemedicine, and as my partner said to me, we'll actually get around to getting a haircut before the waiting lists are down to pre-COVID levels. But probably at that point we should move to our first speaker. So I'm very pleased to introduce Dr. Andy Jones, who's been in the UK healthcare system for a long time and has been Chief Executive at Ramsay Healthcare UK for a number of years. So Andy, over to you.
Thank you, and thanks everybody for the invitation, and good to see everybody that's joined the session. I'll just give a brief overview about Ramsay and our approach. I'll talk a little bit about the pandemic and our response both here in the UK and internationally, and then perhaps a few comments about how we see the future panning out. Ramsay's an Australian listed healthcare provider. We're one of the 4 main global operators working out of 11 countries at the moment. We're well known for our private care, particularly in Australia, France and Sweden. We have a reasonably small operation in the UK, albeit we are one of the largest partners to the NHS and have been very proud to play our part during the pandemic. The company is pretty significant. We work out over 400 locations globally. We've got 8.5 million patient episodes a year, and we employ around 80,000 staff. The company strategy has been pretty consistent over many years in terms of growth, efficiency and sustainability, and I probably won't go into huge amounts of detail, but I think one thing that we're always mindful about is reform in healthcare, reform in markets, changes to processes and systems, and I think now is a time where we're going to see that accelerate in every country. The pandemic has clearly been massive in many of the countries that we operate. We do have one hospital in northern Italy which clearly got hit first, so one of the early tasks was to translate intensive care documents from Italian into French and then into English as the pandemic spread. The main part of our response has been to partner with governments, so we have signed agreements in Australia, France, Sweden and the UK to play our part, because clearly it was the thing that was required and was the only rational and sensible thing to do. As a company, our response has been pretty much typified by making sure that we play our part. We're part of the system, we're part of healthcare in every market, so making sure that all of our facilities got involved in supporting the national response to a pandemic. And then, you know, our motto is people caring for people, so looking after our staff to make sure they do a great job, particularly as we've had thousands or hundreds in the UK, thousands globally that have volunteered to work in intensive care units and the like. And that's really to make sure that we can maximise our response to patients. I mean, it's pretty well documented that pandemics have tested infrastructure to the limits, and I'm sure there'll be some informed questions about infrastructure. And you know, that's really been what the pandemic was been like for us in the UK over the last year, really testing for facilities. You've seen real demands on staff, particularly in the critical care section, and a little bit on kit in the early days. The response in second waves to just, you know, in most countries and certainly in the UK for the private sector has been about prioritisation. So in the early wave, it was all about infrastructure. Then there was a recovery in September as many operators, public and private, started to ramp up volumes back up to Christmas, where, you know, we all hit some degree of normality in November. And then unfortunately in the UK, back to square one. So for the last 3 months, we've been very orientated towards cancer surgery and that principle of prioritisation, which I think will no doubt come up now and into the future, about when you're dealing with a backlog, which categories of patients do you treat in which order to maintain some kind of fairness as the market responds. In terms of the future, I think every country will have debates around their infrastructure. I mean, I think Germany has been the exemplar in having excess ICU capacity, and Germany has imported urgent patients from France and Italy at times of need. But other countries have taken this very differently, and you know, it's just interesting to see the acceleration of healthcare reforms in France and other places, and no doubt we'll have our own version in the UK. For a provider such as ourselves, you know, in main part, it's back to our core operating model. So get those high levels of productivity, particularly around diagnostics and day surgery. But I think the pandemic has also put something else in plain sight, which is operating models. So we, like I'm sure many others, are accelerating our digital investments, our technology investments, to make sure as much of our operating model is in the cloud as is possible, and that unlocks all kinds of different pathway reforms, different ways of working, location and setting. So really, just to end, our hospitals are getting pretty full again. The recovery is in full swing. We're seeing demand in private, demand in NHS. There's a bit of a hiatus in terms of NHS policy and where we go over the next 6 to 12 months, which we're waiting to see. So I think clarity around waiting lists and waiting times in the UK will certainly come. And really, every government has a choice around increased spending and reform, and those conversations are playing out again in every territory that we work in. I'll leave my opening remarks there, so I'll hand back to you, Hugh. Thank you.
Great, thanks very much, Andy. So I think interesting introduction there. Move over to Catherine Twomey, who's the Finance Director at the New Victoria Hospital, which I did go to a couple of years ago. Obviously undergone fairly major investment in recent years, so it'd be interesting to get your views, Catherine.
Thank you. Welcome and good morning. It's been an amazing year for those of us working in healthcare. We have witnessed radical changes with many upsides and downsides, and with many twists and turns along the way. And from my personal observations, these are some of the issues that we've had to address. With cancellation of non-urgent procedures, the patient backlog is growing, which is contributing to further treatment delays. We've also experienced a high incidence of patient cancellations due to COVID infection fears. And some patients are avoiding hospital completely, and for others, minor conditions are now more acute. Doctors who were once loyal are going elsewhere and taking up theatre sessions with competitor hospitals. They will go wherever they can be accommodated, and in many cases, loyalty has disappeared. We have experienced last-minute staffing shortages resulting in list cancellations, which is adding to our already growing backlog. Although COVID testing is essential for patient safety, it's been very disruptive and costly for healthcare providers. Patient testing prior to admission was necessary, and if the patient tested positive, the patient's procedure was cancelled, with hospitals left with an unused theatre or consulting room allocation due to time pressures. Next slide, please, Jade. But as a sector, we have delivered despite these problems and have all learned from this. The pandemic has shaken the healthcare sector to its core, but one of the key lessons for the future is that we all need to be more resilient. We need to ensure, for example, that our healthcare infrastructure is adaptable and nimble to meet unforeseen demand. And this applies to our buildings. We need to flex patient bedrooms to accommodate unforeseen intensive care demand. Our IT systems to enable us to be more reactive to current situations, and of course, our staffing. During the pandemic, hospitals were forced to provide physically distant care provision, which included telemedicine and remote consultations. In fact, 3/4 of GP surgeries now conduct some patient consultations via video. What can we do to make it better for our future patients? How can we make it easier for patients to approach their care needs? Well, healthcare can look to the aviation industry for inspiration, so we can give our patients ease of access to our healthcare systems. A seamless process, but complex behind the scenes. Healthcare has generally taken a battering, and with the procedure backlog, there are numerous opportunities for private healthcare to continue to collaborate with the NHS to help clear waiting lists. Next slide, please, Jade. So, let me sum up. Good governance and risk management. We want to maintain high standards and not cut corners on governance and risk management to uphold the highest standards of care, even in difficult times. Effective information flows. Underpinning all of this, we must have robust information systems. You will probably agree that some systems currently are clunky and cumbersome. Skilled and supported staff. We must provide ongoing training to ensure our workforce maintains the necessary skills and support. We need to build resilience into our healthcare systems, processes and staff plans to adapt to future upsides and downsides. Finally, stable funding and adequate health service costing. We need to make sure that the lifeblood, that's the money, is there to deliver and to allow healthcare providers with funding to clear patient backlogs. We will need to examine pricing strategies, patient billing practices, as well as examining the NHS private funding arrangements to ensure our organisations can ride another downturn. We have had a year of firefighting, and now we need an investment pool to enable us to take technology to the next level while maintaining our operating profit margins. To conclude, we have done efficiency, doing things right. We have done effectiveness, doing the right thing. We are masters at competitiveness. Now, we need to do resilience so that we can all do all of these things. That's efficiency, effectiveness, and competitiveness for our patients, for a reactive, responsive, and robust healthcare system to clear the backlog. Thank you.
Great, that's great. Thanks very much for that, Catherine. Now, I think before I move on to my next speaker, I just want to say there is an opportunity to ask, to sort of post questions and also to look at questions that other people have posted and to vote for those if you think they're good questions, because we hope to have quite a long Q&A session. So obviously it'd be good to get a few more questions going if you can all do that. Anyway, so next speaker, obviously cancer, a massively affected sector by COVID, and delighted that we've got Professor Gordon Wishart, who's the Chief Medical Officer at Check for Cancer. So over to you, Gordon.
Thank you very much, Hugh, and thank you for asking me to participate in this really important discussion. So as a breast cancer surgeon, I spent many years working in the NHS trying to modernise cancer screening and cancer diagnostic services, and now doing the same as founder and chief medical officer at Check for Cancer, an early cancer detection company. So it's not surprising I'm going to discuss this from a cancer perspective. So in this short introduction, I'd really like to do three things. I'd like to just summarise the state of cancer services in the UK before the pandemic and lockdown. Then I'll look at the impact of both on cancer services. And then in my last slide, I'll look at where I think we need to go next. So thank you. First slide. So a report by CR UK in April 2019 looked at cancer services in the UK and concluded that we had worse survival than many Western countries, including Canada, Australia, Norway, and Denmark. And if you look at the diagram on the right, you'll see that although the UK has made improvements in the 5-year survival of lung, breast, colon, and rectal cancer, we're still lagging behind these other countries. The report documented that the worst survival was due to inadequate early cancer detection and lack of access to optimal treatment. For example, the 62-day target, whereby 85% of patients are meant to start treatment within 62 days of an urgent cancer referral, has been consistently missed since 2014. And it's no surprise that the report documented shortages of cancer treatment specialists, lack of access to imaging, and that extra resources were needed to try and put that right. So all of that really adds up to saying that prior to lockdown, cancer services in the UK were creaking, they were working at capacity, and it was very obvious from April 2020 onwards that the NHS would be in a poor state to manage any cancer backlog after lockdown. And next slide, please. So there were two main impacts of the lockdown. People scared to leave their house, struggling to get an appointment with their GP, and then disruption of cancer services and secondary care, where resources were diverted to dealing with COVID. The 4 UK cancer screening programmes were suspended or paused between March and July 2020. We normally screen something like 200,000 patients a week in the UK. So these were large numbers of people who did not receive their appointment, and many have still not received their screening appointment. And then there was a massive reduction in urgent cancer referrals for the 3 reasons that I mentioned. And all of this has added up to something like 40,000 missed cancers in 2020 compared to the previous year. Over 3 million people missing their screening appointment. And that led to a difference of about 8,000 in screen detected cancers diagnosed in 2020 compared to 2019. So many of those will not present until they get their screening appointment, or if they develop symptoms. More recently, some data from the South East London Cancer Alliance has looked at a change in stage at presentation, and they've shown a 4% increase in advanced stage and almost 7% increase in stage 4 cancers. So those are really quite advanced stage, incurable cancers. And that greatest stage shift was seen in lung, colorectal and prostate cancer, which are cancers that tend to present late in any case because symptoms tend to present quite late. So really a massive effect on cancer service as a result of lockdown. Next slide, please. So what can we do about this? Well, I've really been astonished that the government has not really acknowledged the scale of the cancer backlog, because until that happens, then they're not going to come up with additional funding to actually prioritise managing this backlog. As we've heard, a number of private providers have been collaborating with the NHS, and the NHS will always look to the private sector to help with any backlog. And the reason for that is that the NHS has no flexibility and capacity in-house. And we need to think very, very carefully about how we modernise our cancer services going forward. And I think, of course, we're going to need extra workforce, we're going to need increased access to imaging, cancer treatment. But I think it would be wrong if we didn't take a chance to review the whole cancer pathway, because that's how we're going to best manage any future attack on our resources. So for instance, when I was first a breast cancer surgeon, about 1 in every 10 patients who came to a clinic was diagnosed with breast cancer. It's now about 1 in 20, but with really very little increase in the number of cancers diagnosed. So we need to think much smarter about who we bring to secondary care, who we bring to hospital for further investigation. So if I give you one example, the Nice Fit study is where they took a large number of patients with bowel cancer symptoms, and they used the FIT test, which is what we normally use for screening, but they used that test at a very low threshold, so it detected tiny amounts of blood to decide who should have further investigation. And they picked up nearly all the colorectal cancers in that cohort. So streamlining diagnostic pathways, I think, will be essential going forward. I'd also like to see screening programs that are based on personal risk rather than population risk. Because I think if you focus on those at highest risk, you will pick up a proportional number of cancers. So I'd like to see a move to risk stratified screening. So I think I'd like to see much more focus on the early part of the cancer pathway through education, making people aware of the signs and symptoms of cancer, risk factors so they can reduce those risks, and really trying to drive forward with cancer prevention, as well as modernising both screening and diagnostic services. Thank you.
Great, Gordon. Well, thank you. That was really interesting and obviously a hugely important area. Again, we are getting a few questions through. Please don't forget to ask questions, and also if you don't want to ask, vote up the ones you would like to be asked. So our final speaker, happy to introduce Dasos Kirtsides, who's the head of healthcare at Shawbrook, who have very kindly sponsored this event. So Dasos, over to you.
Thank you. Thank you to all the panelists and everyone who's registered. Yeah, just a little bit about Shawbrook, and then I'll go on to the main topic. I mean, Shawbrook is a specialist UK lending and savings bank focused on property finance, business finance, consumer lending and savings. We differentiate ourselves by concentrating on the markets where our expert knowledge, judgment and personalised approach to lending offer us a competitive advantage, so not trying to be everything to everybody. In terms of our healthcare experience specifically, healthcare is what we do, and funding is just the part we play. And over the last 3 years, it has been a year of growth and development for Shawbrook. With over 20 years of experience working within the NHS sector, we took the opportunity to review our offering, in particular looking at ways in which we could further assist NHS trusts, healthcare operators, elderly and specialist care services, and notably in relation to today's topic, private medical and diagnostics businesses. Our focus is always on how does our funding help to deliver better outcomes for their patients and residents. Our primary thought process when considering a new funding opportunity is always focused on how many lives will our money reach and how many lives will it save. And since our relaunch in May 2019, we have extended our healthcare lending portfolio to over 170 million to businesses who do a fantastic job of supporting the wider healthcare sector, including specialist clinics, advanced cancer treatments, medical health, mental health, elderly care and children's services, whilst at the same time we continue to provide funding solutions to specialist adult homes, dental groups, pharmacies, ophthalmology and private practice and to most of the specialist clinics. And we haven't forgotten obviously about the NHS, which is a big part of our business. Despite the challenges of COVID-19, we continue to work with our existing clients and also managed to take on new businesses that needed our support through the pandemic to help them adapt, survive and grow. This reflected the breadth of healthcare operational services that we now support. We increased our client base in both the NHS and private sector. And following on from our 2020 successful results, I believe that our team now is well placed to continue assisting small and large healthcare businesses, in particular those that are working within existing and newer medical fields. Looking forward to 2021 and beyond, we believe that this will be a year whereby we continue to contribute substantially to the development of the sector, supporting healthcare businesses as they focus on securing the facilities to deliver an optimum service for their residents, service users and patients. And in terms of the topic for today, we believe that we play a small part, but a significant one in the food chain. The rest of the panelists and you guys play a much more important role by actually providing the service. And for me, the issues need a clear and well thought out plan to fund the backlog. Otherwise, there's a real danger that the NHS waiting times could become a more of a political issue. And we all know what that means for the next election and how the politicians play on the NHS heartstrings to win an election. At the moment, we're talking about a backlog of anything between 4 and 6 million procedures. But as Hugh mentioned earlier, that is obviously set to rise by the end of the year with the added pressure from the hidden waiting list. Those who put off seeking with help with no confidence of the spread of COVID-19, but then get to a point that they finally visit a GP. Even pre-COVID, the NHS operated at the top of its capacity for far too long. And it will take years to get through the backlog as it currently stands. And therefore, in my view, a continuation of the NHS's successful relationship, or as Catherine nicely put it, collaboration with the independent sector will be absolutely key and essential if they're going to provide a world-class service and save lives. I have seen it in action firsthand on many occasions. The current private NHS deals that have been put in place have enabled over 2 million operations, and this needs to continue. Why wouldn't the public want more MRIs, CT scans done, wherever it may be, in a hospital or within a state-of-the-art trailer in a car park? Please don't get me wrong though, I'm not talking about full privatization here. Just merely stating the obvious about how we can continue processing these procedures by putting the two together, saving lives of many individuals who have waited for months to be cared for and now need immediate attention. Lastly, from me on this is that we have funded plenty of businesses that have worked fantastically well with the NHS and at reasonable fees, which has resulted in lives being saved and/or people's mobility, and those who have suffered in silence patiently for an operation have been treated. So on that note, I will leave it there and move back to Hugh and the important people that actually operate and look after the front line. Thank you.
Great, thanks so much, Dasos. So we've got some good questions in already, but do keep the questions coming in and keep voting for them. So top of the list, a question from Keith Pollard about what impact will COVID have on the pricing of private healthcare? I guess will private hospitals take the opportunity to put prices up, or will insurers come and beat them up even more than usual? So perhaps start with Catherine on that one. Catherine, have you got any views on that?
Yes, well, I think it's important that in the private healthcare sector that the insurance companies align with us to help the patients who are coming to the private healthcare sector with regard to reimbursement. And one area on pricing that I'm currently experiencing as an issue is reimbursement for COVID costs. And I think if we could get consistency across the healthcare, the insurance sector on reimbursement, that would be very useful, for example.
Good. Andy, you must have some views on this. Obviously, I know you do a lot of NHS work, but you also do a pretty significant amount of private healthcare as well.
Yeah, I don't see price moving, to be honest, Hugh, for two simple reasons. The work with the NHS has been a partnership, and obviously a national tariff frames any kind of pricing infrastructure we have in the UK. It's the same in other countries, France, for example. In relation to the insurers, again, it's a contractual commercial relationship, but the reality is that has also been a partnership of understanding this year. It's been very difficult servicing private patients and meeting the demand. But the insurers are going to want to get their patients treated, and the good news is that private work is flowing through hospitals as we speak. But again, the agenda to reform, to modernise pathways, day surgery, rapid access to diagnostics, they're going to be more important. But healthcare typically isn't that elastic, and it's very inelastic in the UK. So I don't see much change to pricing conversations.
Okay, Gordon, would you like to add anything to that?
I don't think so. We're not really involved in cancer treatment, and so
okay.
I think I'll leave that to those that do.
Right. So another question we've got from Sarah Skews about use of existing estates, flexibly, etc., etc. I don't know. Maybe I should start with Andy on that one. Are you seeing any change in the way you'll use your estates post-COVID?
Well, there's been a lot of reform in healthcare over many years, as you know, Hugh. So the growth of day surgery, the growth of diagnostics. So I would say over the last 7 or 8 years, all our estate in the UK has been reconfigured for day surgery. We opened 2 new hospitals last year. They were day surgery hospitals with diagnostics. All of this stuff is now highly tempted and designed so that the building can be reconfigured for the future. But for us, the growth in day surgery driven by pharmaceuticals and medical devices, the demand for diagnostics as that kind of front end funnel are the most important things. I can't imagine a time where in the private sector anybody will be building a hospital with a bed in it in the next few years. It's all about throughput, pathway, digital tools. Really does everything that we do in a hospital actually need to be there, given that half our patients now start their journey online. So very different configuration pressures on hospitals, and like many things from COVID, have only been accelerated with the pressures that have been placed on hospitals.
Catherine, again, I mean, you obviously have done a lot of investment at your site over the last few years. Do you sort of see any further changes in how you will use the real estate post-COVID?
Sure. As I agree with Andy's comments, we've seen particularly a reduction in overnight stays and an increase in throughput, more day case procedures nowadays. And particularly now during COVID, the incidence of day cases has skyrocketed. So we need to build our facilities to accommodate quick throughput.
Okay, that's good. But I think I'm going to move on to a question from Pierre Guillot about kind of where are the biggest bottlenecks? Is it is it actual physical capacity? Is it staffing? Is it funding? Maybe Gordon on this one, I think, actually, because obviously this is very relevant to cancer services.
Yeah, well, I suppose that there's been a lot of funding for a variety of things during the pandemic. And so the funding is there if the government has the will to do it. I agree with what's been said about workforce capacity. And certainly lots of my surgeons of my vintage are really looking to leave the NHS. 20 years of trying to manage cancer waiting times, now the pandemic. And as you said, Hugh, their pension pots are full. And a lot of them have just had enough, and losing that really senior group of cancer specialists, I think, will present a big problem. But whether they're operating, in the NHS or the private sector, with a change in the way that consultants might work with private practice providers in the future on more permanent type contracts, I think that will be attractive for a lot of people and leave a void in the NHS. So I think workforce could actually be one of the biggest issues going forward.
Okay, that's interesting. So with Dasos, have you got a view on this from a funding point of view? Are people coming to you with sort of different funding requirements? I don't know, for high cost equipment or buildings. Are you seeing any changes as a result of COVID?
Yeah, absolutely. I mean, the simple question to even what Sarah asked earlier was, the quick answer is yes. We're seeing quite a few opportunities where there are those public and private, I've got to be careful what I say because it's not PPP or PPP, it's initiatives where they are using the capacity or the existing capacity, car parks where half are closed or half are not being utilised as fully as they should be used, and putting a trailer with a high state-of-the-art MRI scanner. We funded 4 in the last 6 months for a private operator who is working very well with the NHS and taking the capacity. I mean, from a personal perspective, I took my dad to hospital for an MRI scan, and it was in a private company, private provider for the NHS in a state-of-the-art trailer. I mean, I don't think he actually cared. We didn't speak about where it was or where, who was doing it. His ultimate goal was to have the scan and go home and get the results. So, yeah, absolutely. Shawbrook have funded, and we're looking at a number of opportunities like that. We're looking at cancer LINAC machines. We're looking at radiology machines. So, yeah, it's time to be, and a message to all banks really, is a time to be entrepreneurial when it comes to the NHS and the healthcare sector.
Yeah, again, just a personal thing. Oh, sorry. Just throw a personal one in here. I know a lot of the NHS are looking at things like moving outpatients and diagnostics off their main sites, but there seem to be quite big constraints in terms of the CDEL capital limits, limiting borrowing and limiting innovative funding packages. I've sort of sensed quite a bit of frustration from some NHS finance directors about the level of central control and limits on actually doing things like that.
That's the biggest challenge actually from my perspective, is that if the NHS finance directors or CEOs, as you mentioned, do not get over the private provider collaborations, then it's never going to move forward.
Okay, actually I'm going to combine a couple of questions. I've got an interesting question from Ted about how efficient can private hospitals be, and I mean, I guess traditionally, sort of when they were treating mainly private patients, sort of a 60% capacity utilization was seen as good, and I don't know if that's changed now. They're doing more NHS patients, but I think another question from Andrew Valentine, which is interesting and sort of linked to that, is that there does seem to be, and you know, I was involved in the independent sector treatment sector program in the sort of the late noughties, when there seemed to be a greater willingness to use private providers to treat NHS patients. I think Andrew's point is there is still resistance, possibly growing resistance. I don't know. I'd be interested in the panel's views on that. So maybe start with Andy on that. Is you know, how much capacity, how efficient can you be, and is there resistance from the NHS to use you, or do you see growing resistance from the NHS towards using you?
No, I'd say the reverse is true. We had strong relationships coming into the pandemic, and you know, when you get a phone call from a CEO saying, can you put your ventilators on a truck because I'm just about to run out of intensive care capacity, that's a phone call that I don't think either side ever forgets. There's been very high levels of collaboration through the pandemic, probably more than anyone realizes, in terms of trust supporting the independent sector, and likewise patients have been split across pathways so that they've had the diagnostics in one place and their surgery in another, just to make sure it's been done. Whole departments have been shifted, so we've hosted chemotherapy day units for several trusts. Breast cancer pathways have moved in many settings. So I would say relationships have never been better, and you know, it also has to be said, without the funding and supply chain support, the independent sector would have really struggled as well. The question is, where now? Everyone has their own operating model, their own strategy, and I think most providers will be reviewing that, but I think it's reasonably predictable as to where most people head. The question is, what does the NHS want to do with the backlog, and what policies are going to be applied to the long waiters and that general principle of fairness in healthcare? And that's not clear at the moment. So, you know, certainly our hospitals will be busy with NHS work, but it's not entirely clear to me at the moment how the money flows, or how that's going to support the clearance of the elective waiting list.
Do you think, given we're sort of, I don't know, 2 or 3 years away from an election, do you sort of sense that even more money will come in? How much political pressure do you think there will be to get waiting lists down before the election, or do you think the government will just sort of rely on COVID as being a good excuse for high waiting lists?
Well, the big unknown is what does the bounce back look like? I mean, healthcare has been incredibly resilient despite everything that's been thrown out. So there will be a bounce back in activity. So I don't think any of us can know what the total size of the waiting list is. I suspect it won't be as big as everyone's making out. It won't be 10 million. So I think as elective operating gets going with the amazing work of the vaccine program, we'll find out what the residual effects are. One thing that we've discovered is that issues are very local. So there is not a generic problem across the whole country. It will be specialty driven and depends on the match of supply and capacity in different areas. And we're seeing that play out as well in terms of conversations. I mean, the government has the Department of Health have been very clear. The future is all about integrated care systems, and the importance of joining up care for frail and elderly patients, which is without doubt the number one thing that the health service needs to focus on. I think the political dimension of cancer waiting, higher levels of complexity and longer waiting times, I think we'll see in the second half of the NHS year once the recovery gets underway.
Okay. So Catherine, if you, interesting, Andy said it's sort of quite localised. They've obviously got a number of sites. You've got one site. How is it in your area? How are you finding sort of relationships with the NHS and willingness to work with you?
Well, similar to Andy's experience, we've had a great relationship with our local NHS hospital and other facilities as well. We've moved mountains to help. I mean, some of our facilities were handed over to the NHS during the pandemic, and I've never seen collaboration or witnessed that previously in all my healthcare years of experience. So I think for me, that's one of my biggest takeaways going forward, is the collaboration that we've experienced, and ensuring that going forward we can actually build on that. And however, we've been reacting to looking after our patients in a very difficult environment, and I guess we can now kind of look back and see what we can do to make it better going forward. And for instance, we've had instances where our theatre sessions have been underutilised, in part due to the cancellations of patients. But I guess if we had a better way of working with the NHS, for instance, if our technology allows us to be more strategic in filling those gaps, then both the private healthcare and the NHS would benefit, and then that would help us with our backlog. So I think a long journey ahead, and lots to learn from our previous 12 months.
Okay, very good. Now, interesting question here for Gordon from Nick Freeman, asking, you know, why does he think the government has failed to acknowledge the uptick in missed cancers? I remember when talked to people involved in the Blair government, obviously cancer was a huge priority. I think possibly because it was a huge concern and seen as a huge area where they could get more votes. But you know, from what you were saying, Gordon, it seems like the government have sort of failed to see this somehow. Any further comments on that in answer to Nick's question?
Yeah, I think I've certainly been, you know, part of writing to the government, both personally and with other agencies, several times in the last 12 months. They can't say that they don't know about it. No, it's been discussed in Parliament. The all-party parliamentary group on cancer and radiotherapy has been very vocal. So they are aware of it now. And I just think it's astonishing that the mantra of, well, we're back to pre-lockdown levels of service, they're relying on that, but without realizing that, yeah, but what about the backlog? The NHS can't possibly be expected to get back up to where they were before the pandemic and clear the backlog without additional resource. It's just astonishing. So I really fail to understand, you know, when we're now at a point where 450 people are dying from cancer every day, and we're down to single figures of people dying with or from COVID. I'm not sure how they can maintain that position.
Okay, no, that's a good answer. Interesting. Well, a couple of other interesting, slightly diverse questions actually. We got something. Hayley Ollier asking, how can social care assist and be part of future resilience? We haven't talked a lot about social care, but obviously it's a key part of the pathway for many patients with many things. There are a couple of other questions. I think I'm going to group a few of these questions together and go around the panelists. Interesting question from Simon Lovegrove about the fact we're focusing on cure. We have a sort of bias towards elective surgery and treatment here. Again, interesting point that the World Health Organization is focusing on prevention rather than cure. And a question from Dr. Manoj about the fact we have focused on surgery. I think we would have liked to have got somebody from the NHS, and we did try a couple of people involved in mental health. Sadly, we're not always able to get the speakers we want, but I think, again, a very good question that why is mental health not more on the radar? And possibly it is only as an afterthought. So sort of various questions there, moving us away from elective surgery into kind of prevention rather than cure, mental health, and the role of social care. So I don't know, let's go around in reverse order. So Gordon, any comments on those points?
Yeah, I mean, I think, as I said in my introduction, we need to focus much more on prevention. It's much easier to stop something in its tracks or treat it at a very early stage, you know, rather than waiting for, you know, someone to develop with present with a really advanced cancer. So I kind of get that, but you know, but for cancer, prevention it must be a target. But you know, if we take cervical screening, for instance, you know, young girls and boys are now being vaccinated, and that gives about 70% protection for future cervical cancer, but it's not 100% protection. So you need to have a really good screening program as well as vaccination at an early age. But attendance it's for cervical screening is dropping. 1 in 3 women under the age of 35 don't go and have their cervical screen. So that's in the UK. You know, and every other cancer will be more difficult than that. So we must always have prevention as a kind of lifelong target. But you know, there are lots of steps along the way if we ever want to get to that point.
Well, why is it we're not? I mean, are other countries better at that? Because I mean, obviously, we do seem to diagnose, unfortunately, more cancers at stage 3 and 4 relative to other countries. Why is the UK worse at that?
Well, I mean, I think CR UK summed it up. It's inadequate early cancer detection. That means we've got, you know, we need to get attendance up for the screening programs we have. Screening should be risk stratified, not just by age. And we should look at additional screening programs. And then we need to actually modernize and streamline our diagnostic pathways. You know, make sure we put our effort into those at highest risk because of the symptoms that they have. You know, we've got lots of technology available now to look at risk, to measure risk through questionnaires, through SNP testing, which is DNA testing. That there's a lot that we can do to embrace the new technology that's around. Okay,
I'm going to move on to Catherine. So sort of 3 topics, sort of prevention rather than cure, mental health, and the role of social care. Any views on that, Catherine, from your?
Well, I think in general, you mentioned about the pressures on the system at the moment, taking into account the current caseload that we've got to deal with, the backlog, but also staff in the NHS are also dealing with the vaccination programs that they must deliver. So, and there's a pressure on the care provision across the whole patient experience. So that's just a big consideration that we need to just bear in mind. And be it in the NHS, and I guess if the government provides the relevant funding, I'm not sure how the private healthcare sector can help with the vaccination programme, but I guess there's opportunities there for that and helping the social care sector as well.
Okay. Andy, any comments on any of those issues?
Thanks, Hugh. So, I mean, our experience in the UK is limited to acute care, but certainly in France and Australia, we're involved in mental health and social care provision to some extent. The thing that unifies all of these things is the pathway. So we're all pathway providers in some way, and it's the reforms to the pathway that are going to change the way that care is delivered. So an example in mental health is just the growth in apps and digital technology to screen patients up front. In social care, it's all about disruption and moving care into different locations, often much more smaller hubs, community based. In terms of your other question about prevention, medicine in the UK is very, very risk based, risk assessed. You know, we ask a lot of questions, we have to fill out a lot of forms, you have to tick a lot of boxes to progress through the pathway. In other countries, the model is different. It's a lot more scan first, ask questions later. So pick the most appropriate modality, put the patient through the diagnostic test, and then see a doctor. So if you like, invert the pathway. And I think that's the thing that would make the biggest difference in the UK. Build out these diagnostic hubs, put patients through scanners or the appropriate test, and then get to a diagnosis and their treatment. So I think we have got a lot of reform to do in the UK, both in terms of policy, but also in terms of the delivery of care.
A good opportunity for me to plug the LaingBuisson diagnostic report there, which actually did highlight at the back, there were quite a lot of international comparisons. And yeah, as you say, we, on all the major scanning modalities, the UK rate of scanning and the numbers of radiologists and histopathologists per million population are a lot lower than most of our European counterparts. So quite interesting to get that perspective from an international operator like Ramsay. So Dasos, anything you would like to add on those sort of themes?
Yeah, I mean, from a prevention, mental health, social care perspective, I guess prevention, you know, we claim to be a world-class service in terms of the NHS, and it is and can be. But why have we got the lowest survival rates for cancer? Why have we got this massive backlog that has built up? We need to unlock that. In terms of mental health, it's something that, you know, COVID-19 has accelerated the focus on mental health. We as a bank, especially, I mean, we've massively resourced and spent loads of focus on the well-being of our people and making sure that they are staying healthy and that they've got the support they need. And I think that links back to prevention, because I'm guessing that, you know, lots of those backlog procedures are probably linked to mental health, where people have suffered over the last 12 months, suffered in silence and haven't been able to see anybody. Or if you haven't got access to an online GP service, then, you know, you're gonna sit down and you're gonna wonder how you're gonna get the help that you need. And then when it comes to social care, I think there's a huge link between social care and the NHS. And obviously that's why social care and the budgets, the NHS budgets are trying to collaborate the two or mix the two. And I don't think it's just about funding. I think Gordon mentioned it earlier about people. We need people to undergo these procedures and look after these people and work in the NHS and social care in the right places to make sure that we, and mental health obviously, to make sure that we look after the right people.
Okay, good. Right, so I'm just thinking we got some other interesting questions. An anonymous question: how has the attitude and preference of privately practicing consultants changed towards NHS waiting list versus private? So I guess, you know, I think we've got a couple of medically qualified people on the panel, obviously Gordon and Andy, but Gordon, what's your sense when you talk to other doctors? How's the attitude changed attitude of consultants changed towards NHS, private practice, doing NHS work in private hospitals? You seeing anything?
Okay, I've a few thoughts on that. I think prior to the pandemic, most of the cancer specialists I talked to and worked with were just exhausted trying to maintain, you know, cancer services. During the initial lockdown, when the whole private sector was requisitioned by the government and largely unused, they were incredibly frustrated because they weren't able to do anything in their NHS hospital and they weren't able to do anything in their private hospital, and they could see the accrual of patients who were going to need some kind of investigation or diagnosis or treatment in the future. And then I think if you marry that with, it's become increasingly difficult, I think, to run a private practice, especially with all the COVID restrictions, you know, increasing costs. I think a number of them are looking for, A, getting out of the NHS, B, looking at other ways to supplement their income, you know, working for some of the regulatory bodies, doing medical legal work, just looking at other alternatives. So I think there's going to be a workforce problem in the NHS and the private sector actually.
Okay. Andy, you must know a lot of doctors. Are you seeing any change in attitudes of doctors?
The doctors have been brilliant this year. It's been for the reasons already articulated, it's been very challenging with the changing types of work that certainly in the independent sector we've been asked to deliver. It's a bit of a myth that private sector hospitals stood empty. At every point the hospitals have been treating patients, it's just been a different type of patient, and obviously that's impacted specialties very differently. So critical care doctors have clearly been in very high demand throughout the year, but cancer surgery has pretty much continued throughout, and now all forms of elective surgery are getting going. So the doctors have had to be very flexible, very adaptable, very understanding as we've had to make the changes. And then of course there's been the whole drive to online and virtual consultations. So I just have huge gratitude and thanks for the clinicians that have worked with us for their understanding. But I always say the best way of keeping consultants happy is to keep them busy. And the good news is that everyone's pretty busy at the moment. So all the noise has died down and everyone's getting on with doing what they like to do, which is treating patients.
Okay. So an interesting question from Darshak Shah, who I know obviously founded New Medica, who used to do, well, I think they still do, ophthalmology at very high rates of productivity, 20+ cataract surgeries a day and lots of screening and AMD treatment, probably much higher levels of productivity. So I think Darshak's question is, aside from technology and infrastructure, the main constraint is workforce, and given we've got a sort of fixed workforce, one way out of the backlog would be to improve productivity. What are the barriers to doing this? And I guess there's sort of a sense of people in the private sector that private sector hospitals may use their workforce more productively than some NHS providers. So I guess any questions on what are any thoughts on barriers to improving productivity either in private or NHS sites? Maybe Gordon, what are your views on that?
Yeah, I think traditionally private practice for consultants in the UK has been largely most of your time in the NHS and a fairly small amount or percentage of your time in the private sector. If that changes and we get a system, maybe not as far as Australia, which can be 50-50 between private and NHS, but maybe somewhere in between, then you will certainly see more productivity in the private sector, because most of the time will be spent dealing with patients, and they're at the center of all of this. We need to put patients first, and if they are being seen in outpatients and they're being treated and operated, there'll probably be more productivity for the time spent in the private sector than in the NHS, where there are lots of other parts to the job, teaching, audit, all of those things. So I think maybe a slight change in the way that consultants work might help improve productivity.
Okay, I don't know, Dasos, have you got any views on this? You obviously sort of get to see quite a lot of different providers across different sectors.
Yeah, I mean, I guess as Gordon again nicely put it, at the end of the day, this is about saving lives or preventative measures. And we've had, just going back to some of the other questions as well, is when we speak to the private sector about collaborating with the NHS, the first 2 minutes are about what was pre-COVID. During COVID, it's brought out a number of initiatives, and what I mentioned earlier about entrepreneurship is that these private providers just want to help. They just want to save lives. They just want to look after the backlog of try and unlock the backlog and help put people through and before they get any worse. But we as a bank, and as an individual, I mean, we're really keen on funding situations where the private sector is helping the NHS. unlock or unleash their full capacity and their you know, their need for helping. You know, the public pays part of their salary to go towards the NHS to help save lives. If you're going to be treated by, if there's a procedure that needs to be done, then do you care where it's done? As long as it's done. So that's my view.
Okay, just looking, we've got a few more questions, but we've only got about 10 minutes. I'll probably pick out some of the questions and then go around the panel to get answers and sort of summary sort of comments, really. So, I mean, one question again, another one from Hayley Ollier about integrated care systems. Any views on what impact integrated care systems might have? I guess there's a question about infrastructure that the NHS is still working with a very traditional model of building hospitals, I think from Simon Lovegrove, and, you know, should we change the way we design and build hospitals, sort of thinking about COVID going forward. Interesting question from Tom Rocks around community pharmacy. Could they do more in terms of being the first point of contact, patient education, stuff like that? And again, an interesting question from Matthew Ravenscroft around reconsenting patients who need to be reconsented now that they've missed their sort of initial slot, and are there interests in things like digital consenting tools? I guess sort of another example of how digital can make pathways more efficient. So a few interesting questions there, but I think by all means, I go around the panelists, ask them to either comment on any of those or just make any sort of closing comments. And as we've got about 7 minutes, if we can keep it to kind of 1 to 2 minutes each, that would be great. So let's go in the order they spoke. So let's start with you, Andy. What are your sort of final comments?
Thanks, Hugh. So we're going to be in a very supply-led market for the next few years. It's going to be very different to the way that we've all managed coming into this. My number one priority in Ramsay is our staff. So looking after people that have worked very hard through this year, have done extraordinary things and come under very unusual pressures. So as an employer and a caring provider, we need to make sure that we look after our staffing base, and that'll make the biggest difference to patient care, productivity, any of the things that we've talked about. In terms of where the NHS goes or public policy, we'd really like to see some mid-range plans. Let's understand what needs to be done to clear the waiting list, to improve access to urgent diagnostics, and improve the prioritization of patients. That's got to happen. It's got to happen now to avoid the cancer death situation, which Gordon has very clearly described during the seminar. In terms of everything else, it'll work its way through. The one thing that we've learned through the pandemic is that healthcare is very resilient, and there will be huge numbers of opportunities and reforms, and people will come up with ideas that we've never heard of or thought of, and the pathways of care will just rapidly change in the next few years. They have to, because of the infrastructure constraint. So I think I think it's going to be pretty busy for the next few months. But the main thing to do is to make sure that patients are treated according to priority and with a high level of fairness across the system. Okay, good. Right, Catherine, how would you like to either answer any of those last questions or sort of sum up?
Sure, just in general. Well, I'm currently working in an independent private hospital in Surrey. And another experience that I've had is dealing with instrumentation turnaround times impacting on missing out on opportunities for providing more help and care to the NHS. So I'm looking at ways to use what we've got to be more efficient going forward. And hopefully with clarity with the NHS agreements and so forth, we can provide more support in the future.
Okay, very good. Gordon, anything you would like to add to those questions or sum up with?
Yeah, I think we just, certainly from a cancer perspective, we need to take time to review all our cancer pathways for both screening and diagnosis and see where the issues are and embrace some of the developments that have been positive during the pandemic and during lockdown. You know, the move to a week of breast radiotherapy rather than 3 weeks. You know, that's been a great development that was accelerated as a result of lockdown. But there will be lots of other improvements that we can make like that. So I think we need greater triage of patients in primary care. We need to send appropriate patients to secondary care. You know, use of telemedicine is great, but it needs to be appropriate. You know, getting to the point where we can take really high quality images of skin lesions and send them to secondary care rather than sending the patient, that would be good. But, you know, I had spent my whole career and training being told to treat the patient, not the X-ray. And I think for cancer, that is particularly important. And telemedicine, I don't think, works well for diagnosing cancer. I think it's great for giving people results, doing follow-up, but that very first part of the pathway, I think, you know, people need access to their GPs to really start that process well.
Okay, Dasos, how would you like to sum up?
Yeah, for me, you know, this is a huge subject. I'd like to thank LaingBuisson and the panelists for making this happen. It's a key topic. For us at Shawbrook Bank, healthcare plays a huge part of what we do, both in the private sector and the NHS, which is something we've been doing for many, many years and will continue to do. For every procedure, there's a life that sits behind that, and that's more important than talking about just 7 million procedures. We're talking about lives here, and that is the key thing for us. And the most important part is that we find solutions to tackle the lives and the procedures that are needed to save those lives.
Okay, great. Well, good summing up. So I think we are pretty much out of time. So obviously, we'd like to thank you all. I think at one point we had over 180 people participating, listening. So thank you for that. Thank you for those who asked some really good questions there. Thank you to all the panelists for giving up your time and participating. Thank you particularly Shawbrook Bank for sponsoring this, and thank you to LaingBuisson for hosting this event. I hope you've all found it useful and worthwhile, enjoyed it. I'm sure we have. So thank you all, and we'll see you at the next event. Gosh, which suddenly gets a plug. Yes, the Private Healthcare Summit. That's a good one. Okay, great. See you all again soon. Thank you.
Thank you.
Thank you.